Thanks, David. Good morning, everybody. Thanks for coming so early in the morning. Would have been embarrassing if no one showed up. So the two myeloid neoplasms I'm going to talk about are AML and CML. There are other myeloid neoplasms, as you can see from this table from the WHO classification. Carl Allen next is going to talk about some of these others, but I'm going to focus on AML and CML. So the way this talk is kind of organized is each of these orange boxes that I put up is kind of a verbatim content specification from the ABP list for PEDS HemOnc. So basically what I'm going to do is take each content spec and then go through some background that hopefully allows you to have the knowledge needed to answer any questions that are about that. So the talk is all geared around these content specifications. All right, so the first thing is to know the incidence of these malignancies and the peak age that they occur. This is a chart that I put together from SEER data on the epidemiology of ALL, AML, and then I added CML in green at the very bottom. So what you can see is that the incidence of AML is pretty constant throughout childhood. It peaks actually in infancy, around 12 cases per million, and then kind of hovers around the 4 to 5 per million until late adolescence, and it starts to go up slowly. The incidence of CML is extremely low, essentially 0 up until the age of about 3, and then goes up very slowly and starts to go up a little bit in late childhood. Obviously, the peak of ALL is very different. So the point of this slide is just to convince you and me not to get old. Each time I give this talk and I approach that 5-0 in the middle and I start to see where the incidence of AML and CML start to exponentially rise, I get a little bit more nervous. But this just goes to show that myeloid neoplasms are really mostly, in terms of public health, a problem of adulthood and not childhood. So the second thing they'd like you to know is the concordance rate of acute leukemias in identical twins. And what's really interesting about this is that in monozygotic twins, the concordance rate between twin A and twin B depends very much on the age of diagnosis of twin A. So if an infant is diagnosed with leukemia, acute leukemia, and has a identical twin, there's essentially 100% concordance with very short latency. There's been one case report of non-concordance, and that's where the twin B developed a viral infection that appears to have immunologically cleared the leukemic clone, which is kind of cool. But what this tells us biologically is that in infant leukemia, it's very likely a prenatal pre-leukemic event, in this case MLL rearrangement in most cases, and then intrauterine transfer of that cell. And then that oncogene is one of the most powerful ones known with a very short latency and essentially 100% penetrance. Now, if the index case is between the ages of 1 and 6, there's about a 10 to 20% concordance rate. And most of these have been demonstrated conclusively to be clonal between the two twins. And there's a longer latency between twin A and twin B being developed in the cases of concordance. And biologically, what is thought is that this is also a prenatal pre-leukemic event, something like a tel-AML1 fusion or in AML an AML1 ETO fusion, and that there's also intrauterine transfer, but that compared to the MLL rearrangement as an oncogene, there's a relatively low risk of the cooperating hits happening, and it takes a longer time for that to happen. And then finally, if twin A is over the age of 6, at the time of diagnosis, there's really minimal increased risk to twin B, and that suggests that there's really no prenatal pre-leukemic event that they shared in the shared placenta. All right, so moving on to leukemogenesis, they would like you to know which constitutional and genetic conditions predispose to the development of leukemia. There are basically 4 major categories of these genetic predispositions to leukemia that I think are worthwhile reviewing. The first is the most complicated, and that's Marrow failure syndromes, which typically are associated with myelodysplastic syndrome in AML. I'll spend the next few slides after this talking about those specific ones, and there's a table in your handout on these. The others that I'll mention briefly here there are JMML-related conditions. JMML is juvenile myelomonocytic leukemia, and that is not covered in this talk, but it's important to note that patients that have neurofibromatosis, Noonan syndrome, and some other constitutional syndromes have an increased risk of JMML. And then, as you all know, Down syndrome patients have an increased risk both of ALL and of myeloid neoplasms, and in particular, they have a risk of transient myeloproliferative disorder and megakaryocytic leukemia. There are a few others that don't fall neatly into one of these categories. Ataxia-telangiectasia is a disorder that can predispose to lymphoid malignancies like ALL and non-Hodgkin's lymphoma caused by mutations in the ATM gene, and that results in a fairly profound immunodeficiency, DNA repair, as well as the ataxia and telangiectasia that the disease is named for. Bloom syndrome is caused by mutations in the BLM gene. These patients have short stature, very photosensitive, and have sister chromatid exchanges at a genetic level. And then finally, hopefully you're familiar with Li-Fraumeni syndrome, which is germline P53 mutations. There's obviously a broad range of malignancies that can result in patients that have Li-Fraumeni, but leukemia is certainly one of them, and there's been recent attention to hypodiploid ALL and its association with Li-Fraumeni syndrome as an index case. All right, so I told you we're going to talk a little bit more about marrow failure and predispositions to MDS AML. So I break these down by the presenting CBC abnormality that the marrow failure syndrome is best known for. So the two that typically present as pancytopenia are Fanconi anemia and dyskeratosis congenita. And so Fanconi anemia, you probably remember, I think it was very famous in medical school a long time ago. There was one kid's picture who was always in the textbooks, and he had like a Dutch boy haircut, he's in a diaper, and he's going like this. So that's all anybody knew about Fanconi anemia until you actually met a patient. But anyway, there are characteristic congenital abnormalities, and these are caused by mutations in one of a number of different components of a protein complex, the Fanconi's anemia BRCA complex. Dyskeratosis congenita is characterized by abnormal skin and nail development, leukoplakia, and mucous membranes, and is caused by mutations in telomerase complex components. So there's one marrow failure syndrome that predisposes to AML that presents primarily with anemia, and that's Diamond-Blackfan anemia. Typically, these patients present with a pure red cell aplasia initially before progressing to bone marrow failure, and there are also characteristic dysmorphic abnormalities. And this disorder is caused by germline mutations in one of several ribosomal protein genes. And neutropenia is the presenting feature of two marrow failure disorders, Shwachman-Diamond syndrome and Kosman syndrome, also known as severe congenital neutropenia. So Shwachman-Diamond syndrome is interesting because it involves exocrine pancreatic insufficiency as well as some skeletal dysplasia abnormalities, and the gene that is mutated is named for the syndrome. And then Kosman syndrome presents typically with isolated severe congenital neutropenia. There are various mutations in neutrophil genes that predispose to or that cause this condition. Elastase is the most common. One thing that's interesting is that often the progression to MDS and full-blown AML entails activating mutations in the GCSF receptor in these patients. Okay, so, and then finally, thrombocytopenia. So these are the conditions that present primarily with low platelets, and those are congenital amegakaryocytic thrombocytopenia and familial platelet disorder with predisposition to AML. So the first is caused by disorders in the thrombopoietin receptor, the so-called MPL gene. And then the second is caused by germline mutations in the AML1 gene, also known as RUNX1. And the interesting thing about the familial platelet disorder is that these patients typically present with low platelets, not only in number but in function, and it's widely variable throughout the kindreds which affected individuals actually present with the disorder and whether they progress to AML. All right, so switching gears to classification, this is kind of a big deal in acute leukemia, is to be able to classify. Each classification category often has different treatments associated with it, different risks, and so it's important to understand that. So it's important that you understand both the old, which is the so-called FAB classification of AML, and the newer classification, because both are referred to in various questions, and then some of the clinical presentations that are characteristic of each. So I try to cover these in one table that's there in your handout. This is the FAB classification, and a couple of things to know is that this was developed in the early 70s, and really morphology was the thing that was most readily available in terms of diagnosis, and so this is a morphologic-based classification scheme. The other thing to know is that in that classification, it was necessary to have 30% blasts in order to make the diagnosis of AML. And I point those things out because it's different in the newer system. So a couple things to highlight is that there are recurrent cytogenetic abnormalities that I'm referring to as the big four that are highlighted here with the red boxes. Those are the 821, 1517, inversion 16, and the 11q23 abnormalities. And each of these are associated with one of these FAB subtypes. So 821 typically occurs in M2 AML, which is AML with myeloid differentiation. 1517 is the PML-RAR alpha translocation that is pathognomonic for promyelocytic leukemia. Inversion 16 is essentially pathognomonic for M4-EO, which is a myelomonocytic leukemia with eosinophilia. And then the MLL rearrangements are most common within the monocytic subtype of AML. Highlighted in yellow are the clinical characteristics that kind of may point you towards one of these FAB classifications. So chloromas are common both in M2 AML with the 821s, but also in MLL rearranged AML, the M5s. DIC is, we'll talk more about this, but this is a classic feature of APL. It can occur in other acute leukemias as well, but is most associated with APL. And then involvement of the CNS, gingival hyperplasia and leukemia cutis is most characteristic of monocytic leukemias, particularly those with MLL. And then finally, the platelet form of AML, which is the M7 in the FAB classification, myelofibrosis, both in the marrow and the liver, are commonly seen. So the newer classification scheme, the definitive book was published in 2008, and there's a revision that's currently in press for the World Health Organization. So this is based primarily on clinical and molecular features, and a requirement now of only 20% blasts. Now that requirement is actually waived if you have one of the genetic abnormalities that I talked about. So if you have a patient you do a bone marrow on and they come back with an 821 translocation, one of the recurrent genetic abnormalities that defines AML, then it doesn't matter what percent blasts are there, they have AML. And that's an important thing. That's a difference between WHO and the preceding. If they don't have a defining molecular abnormality, then you just require 20% blasts in the bone marrow to have acute leukemia. So the WHO is, I think about it diagnostically as a series of questions you ask yourself about the patient's case. The first question is there AML due to or associated with prior therapy, either radiation therapy or chemo? And if the answer is yes, then it's a therapy-related AML. That's the diagnosis. And that's irregardless of any other molecular features or clinical features. That's their diagnosis. The second question is this AML case happening in a kid with Down syndrome? If so, then it's Down syndrome-related AML, again, regardless of other features. The third question is one of the recurring abnormalities, genetic abnormalities present. And again, I'll talk about the big four. These are the most common and the ones that are most commonly tested. And if yes, then the diagnosis is AML with that abnormality. And those abnormalities, again, are the 821 translocation, inversion 16, the 1517 translocation, and MLL rearrangement at 11q23. You'll notice I'm going to repeat that over and over because it's striking how many questions on the boards are about these four things. And again, note that there's no minimum blast percentage needed for this. The final question is the case associated with dysplasia, a prior myelodysplastic syndrome, or a MDS-related mutation, things like monosomy 7 or 5q-? And if the answer is yes, then the diagnosis is AML with MDS-related changes. And if the answer is no to all 4 of these questions, then the diagnosis is AML not otherwise specified, and then you defer to the FAB classification at that point to further subclassify. So FAB is still used, that's why it's important to know it, but it's only used in cases that don't have one of these 4 features. So hopefully that clarifies the diagnostics and the classification of AML. So to go into a little bit more detail on some of these classes of AML, I want to talk about therapy-related AML first. The board would like you to know the characteristic chromosomal abnormalities and clinical characteristics in secondary, that's what it used to be called, now we call it therapy-related AML, resulting from topoisomerase II inhibitors and from alkylators, respectively. So alkylators and radiation are a risk factor for therapy-related myelodysplastic syndrome and AML. The presentation of therapy-related AML and MDS after alkylating agents and radiation typically has a long latency from the exposure. The median is 5 to 7 years. And there's commonly a preceding MDS phase, a myelodysplastic syndrome phase that precedes the development of AML. The cytogenetic abnormalities that characterize this are things like monosomy 7, deletion of the long arm of 7, monosomy 5, deletion of the long arm of 5, and complex cytogenetics. Now, this is very distinct from this therapy-related AML that results from exposure to topoisomerase II inhibitors. And the most potent topoisomerase II inhibitor that's commonly in use in pediatrics is etoposide, but anthracyclines like doxorubicin, daunorubicin, mitoxantrone are also topoisomerase II inhibitors. So anthracycline exposure can also be associated with this developing. The latency is extremely short compared to alkylators and radiation, typically on the order of 1 to 2 years. And very rarely do you detect a preceding myelodysplastic phase because the latency is so short and it's such an aggressive leukemia when it develops. MLL rearrangements at 11q23 are by far the most common cytogenetic abnormality in therapy-related AML resulting from topo-2 inhibitor exposure, but any of the other recurring cytogenetic abnormalities and even molecular abnormalities can occur. We recently had a case of a kid present with nucleophosmin mutated AML as a result of prior therapy. So it's not just MLL, but it can be really any cytogenetic abnormality that occur. By far, MLL is the most common, however. Regardless of age at presentation or the preceding exposure that caused the therapy-related AML, in general, this tends to be more refractory to therapy than de novo MDS or AML. Okay, so again, I'm going to hammer down on these recurrent cytogenetic lesions because there's a lot of things in the board specs and they ask a lot about it. So they'd like you to correlate clinical characteristics with these abnormalities, which we started on, understand the significance of rearrangements of the ATRA receptor in M3 or promyelocytic AML, recognize specific clinical syndromes associated with these cytogenetic abnormalities and the molecular abnormalities with which these things are associated. So you can tell this is an old content question, this last one, because they call it acute non-lymphoblastic leukemia. I'm pretty sure the last time that phrase for AML was in vogue was before I was born, and I won't tell you when that is. All right, so here again are the big 4 cytogenetic abnormalities. So the first column is the cytogenetic finding. Second column are the actual genes that are involved in the translocation. Seems like every few years the powers that be change the names of these genes. So the AML1 ETO, as we used to call it, is now RUNX1T1. Just really rolls off the tongue, doesn't it? Thank goodness PML-RAR alpha has stayed that. There are some variant translocations with RAR alpha, but by far PML is the most common. In version 16 is CBF beta and the MYH11 gene fusion. And then finally MLL. Probably the most confusing thing that happened is they changed the name of MLL to KMT2A. Lysine methyltransferase 2A. Again, just rolls off the tongue. So I still call it MLL. I hope you don't shoot me down for it. All right, so each of these cytogenetic abnormalities is associated with one of the FAB subsets shown in the third column, and then finally, some of the characteristics that we've covered. So this table, I think, is really important, something for you to know very well, and we're going to go into some detail on the 1517, since they asked specifically about that. All right. So here's the 1517 translocated AML. This is acute promyelocytic leukemia, and they'd like you to understand the significance of these rearrangements and of the ATRA gene. And so Here is kind of a schematic of how the 1517 translocation messes with a cell function. So the retinoic acid receptor, it turns out, is really important not only for myeloid differentiation, but for other tissue differentiation as well. And so when the retinoic acid receptor is involved in this translocation, that signaling gets interrupted, and the cell is blocked at a relatively early stage of myeloid differentiation at the promyelocyte phase. And so when you give exogenous ATRA, you can overcome that signaling block and reestablish differentiation, and the cells, the leukemia cells, are able to differentiate past that block and undergo apoptosis. And that's basically the effectiveness of ATRA in a nutshell. And so what are some of the clinical aspects of APL? Well, there's a very high risk of life-threatening bleeds, about 10% mortality within the first few weeks of diagnosis due to severe DIC, fibrinolysis, and low platelets. And so it's important to closely monitor coagulation abnormalities, fibrinogen, PT-PTT, D-dimer, and platelet counts, and liberally use products, cryo, FFP, and FFP. It's important to start ATRA as soon as possible in these cases. Probably the first thing I do if I'm on service and I get a call about a potential new leukemia is I want to look at a blood smear and I want to think about whether they have APL, because the biggest mistake I can make as an attending is not to start ATRA soon on a case of APL. And there's really very little harm in starting ATRA on someone who ends up not having APL, so you should have a pretty low trigger to do that. And the reason is because that fairly rapidly improves coagulation factors and has been shown early ATRA to reduce bleeding risk. So other interventions other than just product replacement are controversial. People have tried heparin, Amicar, recombinant factor 7A with mixed results, and so it's not standard practice to do that. The second thing that's important to understand about ATRA is that it can cause differentiation syndrome, and this can be a real problem. It's kind of like a cytokine release syndrome, if you will, and as these cells differentiate to more mature granulocytes, they can release the contents of their granules and induce a really fairly profound inflammatory reaction characterized by fever, pulmonary edema, hypoxia, et cetera. And the risk of this correlates with the circulating white blood cell count at diagnosis, and that's why we use 10,000 as kind of the cutoff for low risk versus high risk APL. One of the reasons for that is not just because of the need for chemotherapy for the high risk, but also because of the risk of differentiation syndrome. The differentiation syndrome can happen spontaneously, even in the absence of ATRA, but with ATRA, it gets much less. So in that case, in that way, it's kind of similar to tumor lysis syndrome. And it's important to promptly recognize this phenomenon and treat it with steroids and hold the ATRA until it's resolving. All right, I want to mention arsenic trioxide. So this is increasingly being incorporated into consolidation for APL. The way it's thought to work is that it actually leads to a breakdown or reduced expression of the PML-RAR alpha protein. And so it's quickly replacing anthracyclines in consolidation. And in fact, the standard therapy for low-risk APL in 2017 is to not use chemotherapy but treat exclusively with ATRA and arsenic based on a landmark Italian study. So that's a pretty cool development within our field. All right, so again, Carl's going to talk about MDS, but I just wanted to mention a couple of things about its relationship to AML, because they ask you to know that. So in children, unlike adults, the vast majority of AML cases are de novo, meaning not preceded by an MDS phase. That's not true, particularly as you get into elderly adults. MDS in children commonly arises in the setting of underlying constitutional disorders. So if you've got a kid that presents with MDS, you should look pretty hard for one of these constitutional disorders I talked about, a Marrow failure syndrome, et cetera, Down syndrome. MDS in children has similar clinical implications as in adults. The rule, it's not exclusive, because some kids have been demonstrated to spontaneously resolve a diagnosis of MDS, but the rule is eventual progression to AML. The pace of that progression is quite variable, as it is in adults. In general, I would say childhood MDS requires stem cell transplant for cure, but there is a questionable role for pre-transplant chemotherapy. In general, if the kid's presenting with a relatively low-grade MDS, there's likely not a substantial role to give them chemotherapy prior to transplant. Okay. Hyperleukocytosis, too many white blood cells in the blood. So the potential complications of this are significant, and they'd like you to know that, and they'd like you to know how to manage it. So what is hyperleukocytosis? So it's a disorder caused by too many white blood cells in the blood, and the risk factor is having too many white blood cells in the blood. One of the things that we know is that all other things being equal, the same count in AML is going to have a much higher risk of causing hyperleukocytosis problems than in ALL. It's probably simply because the AML cells are typically bigger and stickier. They have a lot more adhesion molecules on their surface, and so the effect of 100,000 per microliter AML cells on viscosity is going to be a lot greater than 100,000 per microliter ALL cells. How this causes a problem is there's three organs that have capillary beds that seem particularly prone to sludging, and those are the brain, the lungs, and the kidneys. And so when the viscous blood sludges within those capillary beds, in the brain that can cause decreased level of consciousness, can even cause strokes and intracranial bleeding. In the lungs, it can cause hypoxia and respiratory distress and infiltrates. And in the kidneys, it can contribute to renal insufficiency. Typically, these patients are also having some tumor lysis problems, so separating out which is due to hyperleukocytosis and which is due to tumor lysis can be a challenge. The management is to treat the leukemia as soon as possible. So make a diagnosis and get definitive treatment as soon as possible. In patients that present with symptoms in any of these organ systems, it is recommended to do exchange transfusion or leukapheresis. That will be a temporary fix at best. You can reduce the white blood cell count and the viscosity of the blood, but by no means is that definitive treatment. It's important to get the chemotherapy started right away. All right. Let's shift gears to immunophenotype. Flow cytometry, as you know, has become pretty much the most important tool in leukemia to make diagnoses, and so it's important to know when your flow cytometrist calls you and says, this acute leukemia you just sent me expresses these markers. Be good if you could kind of sort that out. And it's good for tests, too, because they like to ask this stuff. So this is a table from Dario Campana's study back in 2000 in the Journal of Immunologic Methods. And by itself, it's not a real helpful tool, but if you go through its components, I think there's a few themes that come out of it that are take-home messages for you. So the first thing is, what markers would you consider pan-myeloid? In other words, these are markers that are expressed on virtually all subsets of AML. And those are these three: MPO, CD13, and CD33. So other than M7 AML, the platelet form of AML, which doesn't express myeloperoxidase, all other cases express myeloperoxidase, CD13, and CD33. There are a couple of markers that are selective for monocytic AML. That's the M5 and M4 forms. The one that's in this table is CD14. There's also CD11B, which is not in this table, but is also another monocytic specific marker. So if the question says that the case expresses 11B and 14, they're trying to tell you that it's a monocytic AML. Glycophorin A, also known as CD235A, is very specific for the erythroid form, the M6 form of AML. And then megakaryoblast AML is characterized by expression of 41A, 42, and 61. The 42 and 61 aren't in the table, but the 41A is, by the absence of MPO, as I mentioned. It's important to understand that the immunophenotype of APL is characteristic, and the things that separate it are the fact that the cells will autofluoresce. So what the flow cytometrist will tell you is that even without any stains on the cells, they will bump up on the APC or the PE channel. So in other words, the cells themselves are glowing as far as the flow cytometer is concerned. So there's a positivity that comes just from the cells autofluorescing, which is kind of cool. They express extremely bright CD33, and they're stone cold negative typically for HLA-DR and 34, and that really distinguishes APL immunophenotype. And as you're struggling to know whether someone should get ATRA, the flow cytometrist can help you with this particular panel. And then the final thing I mentioned, it's not in the table, is that the 821 translocated cases, these are the AML1 ETO or RUNX1, RUNX1T1 cases, often co-express CD19, which you probably know is an ALL marker, but co-expression of CD19 on 821s does not is not unusual, and it doesn't mean that they have a mixed phenotype acute leukemia. It's just a characteristic of that subset. Okay, so I mentioned mixed phenotype acute leukemia. So there are two classes in the WHO classification of what are called acute leukemias of ambiguous lineage. The first is undifferentiated leukemia, and these are acute leukemias that express so little on their surface that you know they're hematopoietic because they have CD45, and you know they're acute leukemia, but they don't express myeloperoxidase or any of the lymphoid markers, and these are very rare but cases that happen. More commonly is the mixed phenotype acute leukemias. So these are cases that either have two distinct population of blasts, one of which is myeloid and one of which is lymphoid, or they can have a single population of blasts that markedly co-express both myeloid and lymphoid antigens. And they both fall under the category of mixed phenotype acute leukemias. Often these cases have MLL rearrangements. MLL was named for mixed lineage leukemia, so it makes sense that that's associated with these mixed phenotype or mixed lineage cases. T myeloid mix and B myeloid mix are the most common of the mixed phenotypes. I'll just mention the treatment of these is controversial, and it's gone in many phases over the years that I've been practicing. So when I was a fellow, I remember any mixed phenotype case was treated with myeloid therapy, regardless of how much lymphoid expression there was. And then there was a shift to initially treating with lymphoid therapy, and then a shift to whatever is the most prominent of the two. In general, I think people feel like this is a high-risk leukemia, and transplant and first remission is the goal. So you'll see lots of information. I think the latest flavor is that you kind of lean towards lymphoid therapy as first therapy. It makes sense that that's probably associated with less toxicity, and if it works and you get somebody in remission, great. But it's a controversial area, and you probably won't be asked about it as a result of that. All right, so let's talk about prognostic factors and risk stratification. So they'd like you to know the prognosis of various subtypes and also the prognostic importance of Down syndrome and the cytogenetic abnormalities. So I just want to highlight in yellow here what we mean by risk stratification and prognosis, because they're often used interchangeably, but they mean they mean different things. So risk stratification is the prospective use of prognostic factors to assign patients to a specific treatment. So there are lots of prognostic factors, but the only ones that are important for risk stratification are those that are actually used to assign treatment. So there are a number of prognostic factors that have been identified in AML that are not used in current risk stratification schemes, and those are shown here on this slide. So first of all, host characteristics like age and sex have not been independent on most recent studies of AML. In terms of race and ethnicity, non-whites have an inferior survival. Body mass index, patients that are markedly over underweight have inferior survival in AML. And then there are host characteristics that are increasingly being discovered in pharmacogenomic polymorphisms that have to do with outcomes. But these are not typically incorporated prospectively into risk stratification schemes. In terms of disease characteristics, high white count, unlike in ALL, is not typically used in ALL with the exception of M3 or APL, where that 10,000 cut of high risk versus low risk is important. And then the FAB characteristics, the morphologic characteristics, used to be thought to be prognostic, and now that's been supplanted by the use of cytogenetics and molecular. So what are the prognostic factors that are used in risk stratification? And I'm going to tell you up until a few years ago what risk stratification in AML looked like, and then I'll update that with what it looks like today. It's a minor change that simplifies things. Well, it's not minor, it's a very important change, but it simplifies things. Conceptually, it's a minor change. All right, so up until very recently, the risk stratification was based primarily on cytogenetics and molecular features. So there were favorable features. So two, right off the bat, favorable features are either having a Down syndrome-related AML or having 1517. These patients are treated on different protocols, and their outcomes in general are very good with upfront therapy, and transplant is generally not incorporated in first remission for these two entities. The other forms of AML that are considered favorable risk would be those with inversion 16 or 821 translocations, and then at a molecular level, patients that have nucleophosphate mutations or biallelic mutations in CEBP alpha. Unfavorable changes include therapy-related AML and MDS-related AML, as I mentioned before. having cytogenetic abnormalities that are associated with MDS-related AML, like monosomy 7, 5q-, etc. And then having a FLT3 ITD high allelic ratio mutation is associated with high risk. Also, patients who don't respond well to induction, so primary induction failures, which we currently define as having greater than 5% blasts after a second course of induction, those patients have unfavorable risk. And in the old classification, everything else was called intermediate risk. So the update now is the incorporation of MRD into risk stratification. And so flow cytometric MRD at the end of block 1 done by a central laboratory in Seattle has become standard for risk stratifying, certainly within the COG and increasingly in other groups as well. So these intermediate risk group is now subclassified into either favorable or unfavorable based on MRD at the end of the first block of therapy, and it's based on the data I'm showing here that show that relapse risk is strongly associated with MRD, and the optimal threshold for this distinction seems to be 0.1%. And so that leads to the current risk stratification, which is exactly the same, except that the intermediate risk MRD negative are in the favorable group, and the intermediate risk MRD positive are in the unfavorable group. All right, so that's risk stratification. You're the low risk or high risk. Now let's talk about what we do with the patients based on the risk stratification. So they'd like you to know a lot of things about therapy. I won't read this entire list, but we're going to go over each of these in the coming slides. All right, so what is the current standard therapy for childhood AML? Well, everybody's got to be induced into a remission if at all possible. And typically, remission induction in AML involves 2 courses of intensive chemotherapy based around Ara-C, doxorubicin, or another anthracycline, and etoposide. Etoposide is the thing that's in common between every induction regimen in AML is the Ara-C and the anthracycline. Etoposide is used most commonly currently up front, but is not used in every group. So remission induction in AML compared to ALL has a much higher risk of invasive infection and a much lower CR rate. So as you know, in ALL, the invasive infection rates are relatively low, even in patients that get a 4-drug induction. The invasive infection rates in the first 2 blocks of AML therapy are extremely high, somewhere in the 25 to 30% range, even higher. And even with that, the remission rate's only 75 to 80%. So our current protocols within the COG switch the second induction course from being kind of more of the same of the first course to a mitoxantrone high-dose Ara-C based course. But that differs by group. The bottom line is that you get a lot of anthracyclines, a lot of Ara-C, and you hope like hell that they get into remission. All right. So after patients are in remission, what do we use for consolidation? Well, there's 2 ways to approach consolidation in AML. Either go to transplant in first remission as consolidation, or continue with chemotherapy alone without transplant. And that decision is made based on the risk stratification. So basically, if you've got unfavorable risk features, typically the approach is to try to do a bone marrow transplant in first remission. So that's all high-risk patients with the best donor available. There continues to be a preference for matched sibling as the best donor. However, alternative donors are becoming increasingly used, for example, haploidentical family donors. And typically, bone marrow transplant is not recommended in first remission for any favorable risk patients, even if they have a matched SIB. So the approach where you use chemotherapy and no transplant, on the other hand, would be only high-risk patients if you really can't find any donor or they're not suitable transplant candidates, and any favorable risk patient. The actual chemotherapy used is usually based around high-dose Ara-C. So typically the induction courses are with what the adults call a 7 and 3 style of relatively low-dose Ara-C, and then the consolidation courses are much higher-dose Ara-C. And then often we combine the high-dose Ara-C with other drugs not used in induction, for example, mitoxantrone or pegosparaginase in the so-called Capizzi regimen for AML. Okay, in terms of CNS prophylaxis, again, AML very different from ALL. You require much less intense CNS prophylactic treatment due to the lower rates of CNS relapse with standard therapy in AML. For patients that do have evidence of CNS disease at diagnosis, weekly or biweekly intrathecal Ara-C treatments until the CSF clears is common, and then once per course after that. Typically, no cranial radiation is indicated in any patients with AML. It's important to understand that maintenance therapy, the kind of the long duration, low intensity therapy that's a very commonly used strategy in ALL doesn't work in AML. It's been demonstrated by randomized trials. You either cure AML or you don't with your upfront treatment, and maintenance therapy is not going to help. So the exception to that, of course, is APL, where prolonged ATRA and increasingly arsenic therapy are helpful. Okay. They would like you to understand supportive care in AML, and this is really important. AML therapy is really toxic. The quality of supportive care can make a huge difference in outcomes. So typically, we recommend admission during periods of neutropenia due to the significant risk of life-threatening, primarily bacteria and bacterial sepsis infections, but also fungal infections. Most of these infections are with strep viridans or viridans family of strep or gram-negative enterics. Aggressive empiric treatment with broad-spectrum antibiotics to cover these organisms should be standard. Bacterial prophylaxis is controversial and really should not be considered standard. Many programs have a concern about selecting for resistant organisms. There have been papers that have demonstrated low rates of selecting for resistance when, say, vancomycin and cefepime are used as primary prophylaxis. In general, it remains a controversial subject, and you'll find very widely divergent practices. So I'll leave it at that. Fungal and pneumocystis prophylaxis are commonly used, and that's a good thing. GCSF and other growth factors are not commonly used in AML due to a theoretical concern of promoting leukemia growth and survival, but also a lack of good evidence suggesting that it does help reduce infections and improve outcomes. All right, so if you are lucky and cure your patient of AML, what do you have to worry about then? Well, depending on what therapy they got, that dictates what you have to worry about. So if they received chemotherapy only without transplant, probably the main thing to worry about is the effect of the anthracycline on their cardiac function. Standard AML therapy involves about 450 mg per meter squared of cumulative exposure, which is significant, and so cardiotoxicity risk is real. If etoposide is used, it's rare, but it's a significant risk of therapy-related MDS AML. And then high-dose Ara-C can be associated with long-term neurotoxicity. If the patient has been transplanted, they've received the chemotherapy I just talked about, so it's all the above, plus all the things that can be wrong with you after you get a transplant. And I don't need to list those for you here, because that would just be depressing. All right. One of the good things about AML is that you rarely need radiation. So they would like you to know the indications for radiotherapy in AML, and they're generally very limited to emergent treatment of life-threatening complications of chloromas. So, for example, spinal cord compression. So the 821 translocated M2 form of AML can be associated, is probably the one that's most commonly associated with bulky chloromas. And so every once in a while that'll happen in a paraspinal region, and patients will benefit from radiation for that. Total body radiation is not typically a component of transplant prep regimens for AML, and cranial radiation is generally not required to control CNS disease. All right, so the last 10 minutes or so, we're going to talk about CML. So I'm always surprised by how much, CML is relatively rare in childhood. When it does happen in pediatric oncology practices, it tends to be adolescents and young adults that are in your practice that get it. We typically kind of backpack on the knowledge that the adults have learned about this disease. There are some unique features of childhood CML which are coming out, but I'm surprised at how many questions there are about this and how many content spec things there are. So even though it's relatively rare in your practice, you should pay attention to this part of the talk and for the purposes of doing well on your boards. All right, so know the clinical lab and prognostic features of CML, the blood changes, know about blast crisis, know about the association of the Philadelphia chromosome, etc. So let's do that. So first of all, defining CML. So CML is one of the myeloproliferative neoplasms. The other MPNs will be covered by Carl in the next talk, but this is the one that falls under my responsibilities. CML is thought to arise from an abnormal pluripotent stem cell, and the driving molecular lesion that's thought to transform that cell is the Philadelphia chromosome, which is the 922 translocation that results in the BCR-ABL fusion. So CML, when left to its own devices, has a triphasic natural history. Most commonly, it presents in a chronic phase, and then if left to its own devices, it will eventually go through an accelerated phase where there's an increase in blasts, and then finally to blast crisis. That blast crisis can be either lymphoid or myeloid. So to dial down on some of the clinical features, most patients are diagnosed in the chronic phase, as I've mentioned. What's interesting is about a third of patients diagnosed with CML are completely asymptomatic, and the diagnosis is made due to an abnormal CBC. And the typical findings on CBC are a very high white count with a left shift. Patients can be anemic but don't have to be. They can and often do have very high platelet counts but don't have to. They often have basophilia and may have eosinophilia. In the two-thirds of patients that have symptoms, the most common symptoms are abdominal pain, dysphagia, and increased abdominal girth. And all of those are the result of the massive splenomegaly, which typically is associated with this diagnosis. Patients can also complain of fatigue, weight loss, night sweats, bleeding, which is an interesting thing. So you would think that having a very high platelet count would be protective of bleeding, but actually you can get acquired von Willebrand deficiency from the types of platelet counts we're talking about. Platelet counts can be up in the 900,000, million, or even greater range at newly diagnosed CML, and that can be a coagulopathy. Leukostasis is not all that uncommon in CML also. The board loves priapism, and I'm not casting dispersions, but I can't believe how often in the content they want you to know about priapism, and I finally saw a case of CML presenting as priapism. I'm like, yes, now I know why it's in the board content specification. So I don't think it's all that common, but my God, they love to put it in the boards for some reason. So just know that priapism can be associated with the diagnosis of CML. All right. So the natural history, as I mentioned, is progression with a widely variable latency. The accelerated phase is characterized by a decreased response to treatment, clonal evolution, so often there'll be additional cytogenetic abnormalities and an increase in blasts, and then blast crisis is frank acute leukemia. Most of them are AML, about a third of them are ALL when they present. So one thing that's interesting is it's sometimes if you have an ALL and it has and it's pH positive, sometimes it's hard to tell the difference between a patient presenting with a lymphoid blast crisis and de novo ALL. And so you really have to rely on two things. One is the molecular diagnosis of which transcript of BCR-ABL is expressed, and I'll talk about that in a moment. The second thing that's really helpful is to send FISH or cytogenetics on a remission bone marrow after the patient's induced, because if they have had a blast crisis of CML, typically they'll have lots of pH left, even in a remission bone marrow, because the normal myeloid is still pH positive. So that's another factor that can help. We've had a number of these cases recently. But probably the biggest clue is whether they express the P190 or the P210 form of BCR-ABL, and PCR standard PCR testing will tell you that. So the smaller P190 transcript of BCR-ABL is associated with ALL primarily, and the P210 with CML. There is some cross between them, but that's the biggest clue between those two diseases. Typically demonstrating the P210 transcript in peripheral blood is sufficient to make a diagnosis of CML. It is standard practice to do a bone marrow, however, on patients to make sure that there isn't kind of a cryptic accelerated phase going on in the marrow, and make sure that you assess for any additional clonal cytogenetic abnormalities that might be present. All right, so the molecular biology of CML should be hopefully familiar to you, but basically the BCR-ABL fusion constitutively activates the ABL kinase. So typically ABL, when it's not translocated to BCR, is very tightly regulated by its ligand, but you translocate it to BCR and that light switch is always on. That light switch is driven by ATP, an ATP binding pocket, which is where the phospho groups come from for all the downstream signals. And the way imatinib and other tyrosine kinase inhibitors work is they basically bind that ATP binding pocket and prevent the phosphorylation of downstream substrates. And that has revolutionized the treatment of CML, as we'll talk about in the next few slides. All right, so the impact of tyrosine kinase inhibitors on CML. It's nothing short of a revolution, I would say. So before the TKIs were developed, the only curative long-term therapy for curative is used twice there, sorry about that. The only long-term curative therapy was transplant. And so basically all kids received transplant with the best available donor. Very often hydroxyurea and interferon were used in an attempt to control the disease prior to transplant. Once the TKIs were developed, that all went out the window, and everybody gets started on a TKI, and you continue it indefinitely. Transplant is controversial in childhood CML. In general, I think the field is moving towards considering transplant in chronic phase only for patients with HLA-matched family donors. Even then, it's quite controversial. So some centers will use the presence of a matched SIB as a reason to transplant someone with CML. That is not uniform practice. I would say that increasingly practice is start a TKI, and as long as patients meet their marks, then that's kind of their indefinite treatment, and I'll talk about what those marks are. For recurrent or refractory chronic phase, the first attempt is usually to switch or try a higher dose of TKIs, guided by mutation analysis that I'll talk about in a moment, and then transplant for treatment failures. Accelerated phase or blast crisis, the idea is to get them back in remission and take them to transplant. That's typically the only curative therapy for that condition. The TKI can be helpful in getting them into remission in that setting. All right, so for chronic phase treatment, I mentioned tyrosine kinase inhibitors. The first one was imatinib. There are now second and third generation tyrosine kinase inhibitors. Recently in the adult literature, dasatinib and nilotinib have been shown to induce more rapid and sustained cytogenetic and molecular responses. So there's an increasing move towards those being frontline treatment for CML, but it's not the wrong thing to do to use imatinib. And then ponatinib is also now available as the one tyrosine kinase inhibitor that's most active against the dreaded T315I mutant. So this is a mutation in the ATP binding pocket that can prevent tyrosine kinase inhibitors from binding, but ponatinib can overcome that. I mentioned that transplant remains controversial. So it's the only proven cure for transplant. The TKIs certainly can achieve sustained disease control, but recurrence is likely upon discontinuation. There are so-called STOP trials ongoing that are trying to understand which patients can have their tyrosine kinase inhibitors stopped and not have their disease come back. Those results are not yet available enough to know what to do with patients on the ground. The major prognostic factor for patients with CML that go to transplant is what was their disease setting at the time of transplant. Were they in chronic phase? Then they'll do better than if they were in accelerated phase or blast crisis. CML is the poster child for being sensitive to graft versus leukemia effects. So it was demonstrated many, many years ago that relapses of CML post-transplant can be effectively treated and even cured with donor lymphocyte infusions, especially if there was no graft versus host disease with the first transplant. When transplant is used, tyrosine kinase inhibitor maintenance therapy can be considered post-transplant. I think it's more commonly used, and the benefit has been better demonstrated in pH-positive ALL, but it's also many centers are incorporating maintenance with TKIs post-transplant for CML as well. I mentioned about patients hitting their marks with CML, so there are specific response criteria that have been developed, and this is hard to keep track of. I'm going to try to simplify it as much as I can. So there's three principal strategies to assess response in CML. One is hematologic response. Basically, do their counts get better and does their splenomegaly go away? Then there's the cytogenetic response, which is typically using FISH on a bone marrow. What percentage of cells have the Philadelphia chromosome? And then finally, and most importantly in 2017, is molecular response. This is the use of quantitative PCR on peripheral blood to give the percent of BCR-able transcripts by an international standard. And so a complete hematologic response is total normalization of counts in splenomegaly. For cytogenetic response, a complete response is not being able to detect by FISH the BCR-able. A partial response is either a major response, less than 35%, or a minor response greater than that. And then a molecular response is defined as a complete response. It would be PCR negative. Typically, that's felt to be a 4.5 log reduction in the number of transcripts is what gets below the level of detection of most modern tests. A major molecular response is having that international standard percentage below 0.1%, or a 3 log reduction in transcript numbers. Okay, the most recent guidelines for response evaluation in CML call for a bone marrow aspirate not to be done if you have validated qPCR testing available for response characteristics. And then when do you do peripheral blood for PCR? The recommendation is every 3 months until you induce a major molecular response, and then every 3 to 6 months thereafter. So these are the marks in this table. So a suboptimal response and a frank failure at various time points. And I'm not going to go over these in detail, but I want this to be there for you to refer to. The bottom line is that to have a suboptimal response means that you're not going as fast as we'd like, and so you might want to consider changing tyrosine kinase inhibitors, doing mutation analysis to see if there's a resistance mutation that's developed, et cetera, whereas failure certainly necessitates a change in therapy and may even necessitate starting to look for a transplant. All right, so response to treatment is by far the most important prognostic factor in CML in 2017. If patients have a rapid and sustained response to TKIs, then they have an excellent outcome. Resistance, however, is a problem. There's both primary resistance, where the patient does not respond initially to tyrosine kinase inhibitors, and then there's secondary resistance, where a patient responds and is having a nice response, but then loses that response. Both of these types of resistance are most commonly associated with the acquisition of a mutation in the ATP binding pocket of the ABL kinase. And there are readily available clinical tests to look for these mutations. The one that's the most problematic, as I mentioned, is the T315I mutation, because up until recently, the vast majority or all of the tyrosine kinase inhibitors didn't really work against that mutation. Ponatinib has been recently FDA approved specifically for that resistance mutation. And then finally, patients that are TKI resistant generally require transplant for cure. All right, so that's the end of my prepared comments. I would be happy to take questions. I think we do have about 6 or 7 minutes before my time is up.
Hi.
Hi.
Is there ever a role for a lumbar puncture in CML up front?
Absolutely. I'm sorry, in CML. I thought you said AML. It's a great question. In general, lumbar puncture in CML is not recommended unless patient has CNS symptoms that would make you worried. One of the reasons for that is the coagulopathy that I mentioned. So most patients will have some degree of von Willebrand factor deficiency as a result of thrombocytosis, and the pretest probability of finding something in the CSF in CML is relatively low. The accelerated phase or blast crisis is a different story. In chronic phase of CML I'm talking about, I don't think a CSF should generally be indicated unless there's some specific concern about CNS symptoms. Great question. I'm glad you brought it up. Yes, sir.
Yes. So if you have a favorable or unfavorable risk in AML before you do the MRD, then you do the MRD for favorable risk, but you have positive. Does MRD take precedence over everything else?
I'm really glad you asked that. I meant to mention that. So in general, favorable or unfavorable risk features trump MRD in AML, at least as we're currently practicing. So for example, if you have a nucleophosmin mutation or an 821 and your N block 1 is MRD on the current COG, you're still favorable risk, because the prognostic impact of the MRD within that favorable risk group is not significant, is not statistically significant. Now, do we worry? Sure. But it appears that the pace of induction response of favorable risk, the kinetics of it, can be slower, and that's still associated with an excellent long-term outcome. Does that make sense? Now, the opposite is true of unfavorable risk. So MRD negativity in a patient with monosomy 7 or with FLT3-ITD does not change the fact that in standard practice, those patients go to transplant. As we get more data, there may be subsets of favorable risk or unfavorable risk where MRD should be incorporated. But for now, MRD is incorporated in decision-making exclusively in the intermediate risk group. But really, great question. Thanks for bringing that up. Again, I don't necessarily consider that so standard of care that it would be fair grounds for a question on a board exam, but it's important, because I think it's very much a clinical decision-making that's in flux at this point. Doesn't mean they won't ask if it's just because it's not fair, though. All right, thank you very much. Good luck on your test, and thanks for listening.